Okay, so I know post-abortion care is slightly controversial in Indonesia, would you say? Yeah? So, so we're going to talk about this, and what's interesting is actually post-abortion care is completely legal in Indonesia. So we're not talking about anything illegal. And then also abortion care is actually legal for certain indications in Indonesia. But post-abortion care is something that's considered a woman's right globally because it's emergency care. So we'll talk a little bit about that today. So I don't have any funding directly related to this topic, so I don't have any biases. I am an IPAS clinical consultant, and interestingly enough, IPAS is an organization that originally started in about 1973 because the US government decided that they would no longer fund abortion care. And because of that, this organization came about, and then also they developed with USAID the ability to perform post-abortion care or emergency care using a handheld manual vacuum aspirator. And initially, IPAS actually manufactured that and then distributed it, but they no longer do. It was bought out by somebody else called DKT, and that's how you actually order the equipment now. So it's completely separate. However, I'm here in Indonesia because of IPAS, so I just want to acknowledge them. And then also, I think I was invited to your university because of Dr. Sinta, is that right? So just, I know she's not here because she's at our training, but I just want to thank her as well. So what we're going to talk about today is just reviewing the definition of post-abortion care and then reviewing the current recommendations for how to safely evacuate the uterus. We'll talk about manual vacuum aspirator, some difficulties or not difficulties with it, and then I did not bring any to practice, although that would have been fun today, but that is not something that we're going to do. But maybe we can come back sometime and do that, because I think it's really important for trainees to learn how to do this, because you guys are the next generation of doctors, and we're going to need you to be performing this for women. Okay. So post-abortion care is considered an emergency, but that doesn't mean that women are actually having a serious complication, but it's considered emergency care. And women can be having post-abortion care either from a natural process, like miscarriage, or because of after safe care that's been done, but they're having a complication, or because of unsafe care that's been provided. So it can happen through a number of routes, but it also covers a number of things. So is this a, no. So is there a, like, oh, there it is. So you can see here that there's a missed abortion or miscarriage, so it's the same thing. And this is basically where the pregnancy has passed away, but it hasn't come out of the uterus yet. And then also there's incomplete miscarriage or abortion. So a process has started, the cervix might be open, part of the products might have come out, but not all of them. And again, this is the one that can happen naturally, or they may have had other care provided to them, whereas a missed miscarriage or missed abortion is one of those things that typically happens normally. And this can happen up to 30% of pregnancies, so it's very, very common. Okay, so for post-abortion care, there are 5 important parts to post-abortion care. The first one is, of course, treatment, and it's, again, considered emergency care. Interestingly enough, how we treat post-abortion care is based on uterine size and not gestational age. So even though you have somebody come in and say, my last menstrual period makes me 10 weeks, but what if their pregnancy passed away 3 weeks ago? So their uterine size is only going to be 7 weeks. And it's important that we know what their uterine size is, because then we know how to treat them. So even though it's important to still get the history around what their gestational age was, if they had an ultrasound that had some dating, the most important thing for treatment is to know what the uterine size is. So you have got to do an exam. And that doesn't mean just an abdominal exam. Do we have a ghost? That doesn't mean just an abdominal exam. You have got to do a pelvic exam. Especially in the first trimester, you have no idea what the uterine size is unless you actually do a bimanual exam, which I know is not something that women line up for, but in order to appropriately and safely treat them, you absolutely need to do the exam. Okay, so counseling, also very important. And then one of the most important things afterwards is to ask them about contraception and family planning. Now, some of these women may want another pregnancy right away, and that's okay. Other women want to prevent a pregnancy, so we want to make sure that they have something to help prevent it. So talking to them, because they're actually seeing you for the care, we can actually provide that care too at that time. There's also other reproductive or health services that might be offered. So if you have cervical cancer screening that might be able to happen, or sexually transmitted infection screening, or HIV, you want to be able, vaccines, anything that a woman could need to get, that's great, have it provided. It shouldn't interfere with her other care, but if you can offer it to her at the same time, then that's great. And then also we want to make sure that we're using all sorts of services to make sure that we're providing safe care in a timely manner. Okay, so what are the uterine evacuation methods? You'll see here that this is for first trimester. It's slightly different, but very similar for second trimester. And different countries kind of use a slightly different definition for first trimester. Do you guys use less than 13 weeks, or what do you use for first trimester? Less than 13 weeks. Some countries use 12 weeks and under, and anything I'm going to talk about today still works for that gestational age group. But the two evacuation methods that are safe and recommended by the World Health Organization are either vacuum aspiration that can be done with an electric pump, or a manual held aspiration device, or medical methods. The medical methods that we use are typically misoprostol based, but for abortion care, oftentimes we'll add mifepristone if it's available, which it's not available here. So we're talking about misoprostol only methods in Indonesia. So those are the methods that are recommended. What method are you guys using? It's okay, you can say it. Are you using sharp curettage? Yeah, okay. So we'll talk about that, but that is no longer recommended, and it hasn't been recommended for a number of years. So this is not a new recommendation, but it's very hard to change. So really hard to change practice. And also, a sharp curette, it lasts forever, right? It's one piece of metal. It's super easy to clean. It's always there, so it's very hard to change. And then if your teachers are teaching you sharp curettage, it's very hard to change because you actually need the right equipment and you need somebody to be able to teach you. Okay, so sharp curettage is considered an obsolete method, and it should be replaced by vacuum aspiration or medical methods. And this is a World Health Organization recommendation. This is not my recommendation. This is a World Health Organization recommendation. Also, the International Federation of Gynecology and Obstetrics also supports these methods and supports them over sharp curettage. So the recommendation right now is, as soon as possible, sharp curettage should be replaced with vacuum aspiration or medical methods. The reason for this is sharp curettage is known to have an increased risk for blood loss as compared to these other methods, increased pain, takes longer, and it has long-term complications like increased risk of Asherman as compared to vacuum aspiration and medical methods. So really the safer option for women is the more modern methods. Okay, so I'm going to talk a little bit about medical post-abortion care, and then we'll talk about vacuum aspiration. So medical post-abortion care is with misoprostol, and I'm just going to abbreviate that with mPAC, so you're going to see mPAC. So you can't use this if a patient is unstable, right? It takes a little bit longer to happen. So if somebody's unstable, having heavy bleeding, needs an intervention right now, you're not going to be using this. But for patients that are stable with no signs of infection, no evidence of heavy bleeding, you don't think they have an ectopic pregnancy and they have normal vital signs, this can be an option for women. So they can use this and cause basically a medical miscarriage for themselves. So if they have a miscarriage already and they just need it to come out, then you can help do that for them. And so they can have more of a natural process that's medically created. What's interesting about this, so for missed abortion, so if you have somebody who has a pregnancy that's demised, that hasn't come out, you can see here for expectant management, it doesn't work very well. So if you're just gonna wait for the pregnancy to come out on its own and just wait, that works 16 to 75% of the time. It's a huge range, right? It doesn't work very well. Also, many of these women need an intervention. So they come in, nothing's happened, they need it to come out, you have to do that for them, or they come in with heavy bleeding and they need a surgical intervention. With medical methods, you can have greater than 90% of the time, they can pass the pregnancy on their own with no intervention at all. And you can get higher than this depending on what kind of pregnancy they have. So if it's incomplete versus a missed abortion, it's slightly different. So you can get rates even higher than 90%. So it can work very well. And then vacuum aspiration, either electric or manual, works about 97% of the time, and most studies show that it's 99% of the time. So why do medical management? Well, some advantages are it's non-invasive. Women think it's more natural because it's a process like miscarriage for them. They can use oral medications. They don't have to go to sleep. You don't need an anesthesiologist. And then also it can be done at home. So if they're stable, you can actually send them home with the medications to do this with warning signs. The disadvantages is that there's some uncertainty in when the pregnancy is going to come out. Typically, it's within a couple hours after taking misoprostol, but sometimes it can take up to a day afterwards. So there's a little bit of unexpectedness regarding the timing. The number of days of bleeding or spotting afterwards can really vary for women. So just like after cleaning the uterus out with vacuum aspiration or even with sharp curettage, you're going to have some bleeding that happens on average about 2 weeks, but sometimes even up to 4 weeks. That does not mean anything's wrong, it's just the natural process. And that can happen with using medications too as well. But sometimes they can have slightly longer time period for bleeding, but that again doesn't mean that anything's wrong. Okay, so what's the regimen that you're supposed to use? So depending on what you have, if it's an incomplete abortion versus a missed abortion, depends on what regimen you use. So this is the regimen for incomplete abortion, and there's a couple different options. So you can either use option 1, which is misoprostol 600 micrograms orally, or option 2, misoprostol 400 micrograms sublingual or vaginal. All right. So for missed abortion, it is different. So the regimens that have been studied have been either misoprostol 800 micrograms vaginally times 1, or the second option is misoprostol 600 micrograms sublingual every 3 hours for up to 3 doses. What's interesting is it looks like if you have an embryonic pregnancy versus an embryonic pregnancy, embryonic pregnancies look like they respond a little bit better than embryonic pregnancies. That doesn't mean that you can't use it for either one, but this is the regimen. But it is different than incomplete. So if you have an incomplete abortion, you want to be using these regimens. And then if you have a missed abortion, you want to be using these regimens. Okay. Anybody concerned about the doses being used here? What do you use for labor? Do you use misoprostol in term labor? Yeah? What's the dose you use? Yeah, right. So you use 25 micrograms. Some countries use 50 micrograms. Some countries even use 100 micrograms for term pregnancies. So these are different doses because the uterus is much smaller. So it doesn't respond as well. So you need to use these higher doses. So a lot of times people really worry about this amount of dose, but actually this is totally fine for the first trimester. Okay. All right, so what are the common questions that we get about medical PAC treatment? So do you think the dose varies if you have somebody who's heavy, twins, if they're younger or older, if they have a prior uterine scar, if they're currently breastfeeding, or if they use misoprostol, like they got some misoprostol from the pharmacy? Do you think the dose should be different for any one of these? Or do you think we just use the regular regimen? You think it's different? No? Anybody else? Yeah, your professor is right. So the answer is no. You use the same regimen for all of these situations, okay? So it's no different if you have somebody who's heavier, if you have somebody with a twin pregnancy that's in the first trimester, that maybe they had a missed abortion and you can see the 2 gestational sacs there, it's the same dose. If they're younger or older, if they've had pregnancies before or not, if you have a prior uterine scar, if they're breastfeeding, or if they use misoprostol outside your facility and you don't know how much, you would still use the same dose. Okay. What about contraception? So you give somebody medical management for post-abortion care, and they're going to start contraception afterwards. When do you start them? What's that? I'm hearing whisperings over here. Do you have to wait? Like, do you have to wait 4 weeks or 6 weeks or? What's that? As soon as possible, yeah. So that's correct. You want to do it as soon as possible. So what's really interesting here are there's some things that you can start immediately because it doesn't matter and you're not interfering with the process or with the uterus. So you can actually start contraceptive pills the same day that they get the medication for their post-abortion care. So you can start them on day 1. An implant, you can put in an implant while you're seeing them. So you can put that in, you can give them their misoprostol, and then they're all ready to go afterwards, which is great. Injection, you can do the same thing. So you can give them the Depo-Provera on the day that they come to see you, and they can do their management. Now the IUD is a little bit different because the pregnancy needs to come out first. So you need to make sure that she's no longer pregnant and just make sure that she's had a process that she feels like was complete and is doing well, and then you can put the IUD in. There's no set time. She may come back 2 days later and feel totally fine, reports that she passed the pregnancy, you do her exam, it's normal, you can put the IUD in. So there's no time frame that's specific. Same thing with sterilization. You can do that as soon as you determine she's no longer pregnant. And then natural family planning, you do need to make sure that her menses have come back and that she can time them and so that she knows when her window is to not get pregnant. So you can't do that right away because she hasn't had a period yet. Okay. What happens if you gave her a misoprostol dose and then 24 to 48 hours later she calls you and says, "Doctor, nothing happened. I feel fine, but nothing happened. Can you repeat the dose?" What do you think? Yes or no? I'm hearing some yeses. Yeah. So you can repeat the dose. However, if you repeat the dose and nothing still happens, then what do you need to do? Yeah, you need to do a vacuum aspiration at that point. Sometimes uteruses don't respond, right? Okay. What about, do you need pain management for medical management of post-abortion care? You think they need anything for pain? What do you guys give people for labor pain? Do you use anything for labor pain? What's that? Methylmalonic acid, okay. So kind of like an NSAID, basically. So anything else that you use? So women report pain with this. And so we feel like it's important to provide women pain management. The pain management that we know works the best is actually a non-steroidal anti-inflammatory. So if you have methylmalonic acid, might be okay. That works more for blood loss than it does necessarily for cramping. So typically we just recommend ibuprofen-like medication. Do you guys have ibuprofen here? Yeah, okay. Some countries, they call it something different. So yes, the answer is that everybody should get ibuprofen when they're doing medical management of post-abortion care. Okay, so what happens if you have somebody that's not in the first trimester? How do you treat them? So actually the World Health Organization does not have a great recommendation for this. They have a recommendation for second trimester abortion, but that's different than second trimester post-abortion care, right? If you have a fetal demise or somebody who had a second trimester or third trimester pregnancy that they passed, but maybe they have a retained placenta, you know, what are you supposed to do with that? So actually IPAS went about doing a systematic review that we had published. And what's interesting is we found really just the same regimen that works for regular abortion works for post-abortion care. So really the recommendation is to use misoprostol, not oxytocin. Misoprostol works much better for these cases and is more effective than oxytocin. It's not that you can't use oxytocin, it just doesn't work as well. So if you want to use something that's more effective, you should use misoprostol for these cases. We know that vaginal or sublingual dosing is better than oral dosing for these cases. And then when available, if you have mifepristone, then using a combined regimen is actually more effective as well. And then you should use at least a dose of 200 micrograms. But interestingly enough, we've found that usually using a 400 microgram dose every 3 hours, there's more data that has come out that 3 hours is more effective than 4, but actually anything in this range is going to work better than using term labor protocols. So oftentimes what's happened, because there isn't a recommendation for this type of case, is people are using term labor protocols with 25 micrograms of misoprostol, and it's too low. Or they use oxytocin regimens for term labor, and it doesn't work well. So, all right, so what about vacuum aspiration? So I talked about there's two different types. There's electric and manual. They work differently because one's plugged in and one's a handheld syringe, but they actually are just as effective. They are able to work just as well, so it doesn't matter which one you have. Either one is totally fine and completely safe. So if you have an electric, great. If you have a manual, great. Some places just have one, some places just have the other. Some places it just depends what room you're in the clinic. You know, like 2 of their rooms have an electric pump, and then the rest of their rooms have a manual pump. So it just depends what you have available, but both are fine. The one that you're probably most familiar with is this one. It's called an MVA+. And because this is registered in the United States, it has a particular indication for it with the Food and Drug Administration. And the Food and Drug Administration has it approved for abortion care, but also post-abortion care, and then endometrial biopsy. So they have a very small cannula that's 3 millimeters that you can use for endometrial biopsy, which is nice because then also you don't have to use sharp curettage for that. And then you can do it in the office, and it just takes a couple seconds, which is really nice for people. So the MVA+ is latex-free, so you don't have to worry if you have somebody that's latex allergic. It has a minimum vacuum of about 500 millimeters of mercury, which is very similar to the electric. And then you can maintain the vacuum for 30 minutes. So if you make the vacuum happen and then put it aside because you're doing your exam and you're putting your speculum in and all of that, it's going to maintain its vacuum during that time. You can use it at least 25 times, but usually more clinics use it a lot more than that. So oftentimes it'll work for even up to 100 or more. It just depends how well you treat it. Obviously, you need to clean it in between each patient, okay? You can't use it this many times and not clean it. And then depending on what your way of cleaning instruments is here, if you have an autoclave or you steam autoclave or you use chemicals to clean things, you can use this either way. Once you've sterilized it, the syringe part here, you can just have in a clean area. You don't need to keep it sterile because it doesn't go into the patient. So once you've sterilized it, it can just be in a drawer or a container and kept clean until you use it again. The cannulas, however, need to be kept sterile until you use them, and then you clean them. There's a couple different parts to them which are important to know how to put them in together and take them apart. And you have to take them apart to make sure that you clean everything. So when you clean it, you would take it completely apart and then you put it back together again. The hardest part is there's this little plastic ring around the top, and you have to be very careful in that some people, because it's tight, some people will use like a hemostat or a tenaculum to like hook it and pull it off, but that will ruin the O-ring. And if you just push it like this, then it'll pop to the side and you can pull it over. So it's actually very easy, but this is usually the hardest part for people. So if you do have this in your clinic, or you're training your nurses or your staff to clean this, you need to make sure that they're not using sharp things to take it off, because otherwise you can ruin it. Again, I didn't bring one today. I'm sorry about that. But basically what you do to create a vacuum is you close these two little buttons and then you pull the syringe out. So it's pretty easy. Now, when you put it back together, one of the hardest parts is people don't put enough or put too much lubricant on the little O-ring, the little black ring. And then that means that either it's really hard to create the vacuum or you can't get the vacuum because there's too much lubrication on it. So typically you need to just put a tiny little bit of lubrication on it so that it's easier to kind of make the vacuum happen. Okay. And then cleaning, which, how many of you guys clean instruments? Yeah, you've cleaned instruments before? Okay, great. So there's a couple different steps. You need to protect yourself while you're doing it, which is really important because, you know, there's infectious wastes on these instruments. So what we do is, as soon as you use it, oftentimes we have a bucket with chlorine in it to put it in directly in there so that the instrument stays wet, and so that it's easier to get off the material, whereas if you just leave it to the side and things dry, it's very hard to clean it afterwards. So we keep it wet, and then that makes it easier. Even though you've done this soak in the chlorine, it doesn't mean that you've gotten all the infectious waste off. So you need to make sure that you're still protecting yourself when you brush off the infectious waste. And then you sterilize or high-level disinfect, whatever your process is here. And then storage, again, you can keep the aspirator clean, but the cannula, the part that goes in the patient, needs to be kept sterile. Okay. The other thing that we use manual vacuum for is a technique called dilatation and evacuation, which is the approved surgical method for second trimester abortion or post-abortion care if you have a lot of stuff in the uterus still. This technique requires special equipment that oftentimes is not available in other countries. So typically, when we get into the second trimester, most of the time that's done by medical management. But we do use the vacuum aspiration as part of that process for the surgical part. And we've done demonstration projects in Vietnam, Cambodia, South Africa, and some other countries as well. And it works very well. Okay, so vacuum aspiration is extremely safe. The major complications are less than 1%. As I said before, it's highly effective. It's less costly because it can be performed as an outpatient in the clinic, just in a regular room. However, we also replace it in the operating room. So if you have a patient that needs to go to the operating room, you just use this instead of sharp curettage. It doesn't mean that because it's in the operating theater that you don't use aspiration. We need to completely replace sharp curettage with aspiration procedures. You don't need general anesthesia, but you might have a patient that needs that level of anesthesia. Maybe you have somebody who's very young or who has been exposed to violence and needs to be asleep for the procedure. That's okay if you have the safe way to provide that. But generally, you don't need that level of anesthesia for this. And it's extremely acceptable to women, probably because they can have this done and then go home. This is just a comparison across different countries of cost. And you probably can't see this in the back of the room, but basically in all sorts of different country contexts, whether in high, middle, or low-income countries, you save costs by introducing this. Not only because this is cheaper than sharp curettage and what happens with sharp curettage, but also because of decreased risks of complications. So what's interesting is this technique is pretty easy. How many of you guys insert IUDs? Have you guys inserted IUDs yet? Intrauterine devices? Yeah, it's basically the same thing, except instead of putting in the IUD, you're doing the manual vacuum aspiration. But it's the same thing. So women-centered care just means that you treat women with respect. You talk to them. You provide them comfort during the procedure. You know, it's just confidentiality, privacy. You provide them counseling, like the things that you would want if you're getting health care, right? So how you want to be treated if you're getting health care, that's basically what women-centered care means. Infection prevention techniques, you don't need to use sterile gloves for this procedure as long as you're not touching the end that goes in the patient. So if the end that goes in the patient, if you're touching it and you can't help touching it, then use sterile gloves. But otherwise, you can just use clean gloves because you're not touching anything that goes into the patient. Also, you know, normal stuff, history, clinical assessment, counseling. I'll talk about prophylactic antibiotics in just a second. We do recommend them when you're doing aspiration procedures. That's prophylactic antibiotics, not treatment antibiotics. We use pain management, which I'm going to talk about in a second. You do the procedure, you provide the contraceptive method, and post-operative care. So that's pretty much it. It's like not rocket science. Okay. So pain control. So women do experience pain during procedures. We know that sharp curettage is especially painful, which is why it's provided in the operating theater. Manual vacuum aspiration can also be uncomfortable for patients, but it can be done in the outpatient because it's less uncomfortable than sharp curettage. That doesn't mean that we don't provide pain control. We know that women are anxious. That increases the risk of pain. We know that women experience pain differently. Everybody experiences pain differently with different things. Women that are younger, women who have experienced violence, and women who haven't had pregnancies before have higher levels of pain than women who don't have those things. What's the optimal regimen to provide? It's kind of a combination of choice, like what does the patient maybe want? Safety, what can you safely provide? And what kind of resources you have. Typically, across the globe, we're able to do this with ibuprofen and a paracervical block, and then possibly somebody might need an anti-anxiety medication on top. That helps with anxiety, but it doesn't help with pain. So there's this whole continuum between nothing and general anesthesia for pain control. And the World Health Organization in general does not recommend general anesthesia for these procedures, but we know that in certain cases it is needed if you can provide it safely. So it doesn't mean that you should never provide it, it just means to really individualize, and the majority of procedures you don't need it. Okay, so there's been a systematic review by the Cochrane. Do you guys know what Cochrane reviews are? Yes? Okay. So this is the Cochrane review. I was part of this review. It's being updated right now. But we know from that review what works and what doesn't. And can you, yeah, jiggle your... So we know that paracervical blocks work for pain control. We know that NSAIDs do. We know that if you combine a lidocaine infusion with the paracervical block, that works. Paracervical block with ketorolac in it works. And we know that moderate sedation, which is using a narcotic IV like fentanyl or sufentanil, works too. It's just that's typically not needed, but we know it works for pain. What doesn't work for pain for these procedures is paracetamol or Tylenol does not work for pain. You can use it for fevers, but it doesn't work for pain. Benzodiazepine doesn't work for pain. You might use it for anxiety, but it doesn't help for pain. Oral opioids, do you guys have those here? No? Yeah. That also doesn't work for pain. Doulas, do you guys know what doulas are? Doulas are like a support person. So that decreases anxiety, but it doesn't decrease pain. So you can have a support person with the woman, which is nice for her. It might decrease anxiety, but it doesn't help with pain. Cervical priming, do you guys know what that is? Cervical priming is where you give misoprostol to open the cervix before you do your procedure. That doesn't help with pain. It causes women cramping. It makes it easier for the provider to get through the cervix, but it does not make it easier for the patient. And then nitrous oxide, which is a gas, like a laughing gas, doesn't work for pain, but it does decrease anxiety. So what's the paracervical block that works the best? So this paracervical block works the best. This is what we know right now. More studies are coming out. And what we know is a 20 milliliter lidocaine block works better than a 10 milliliter block. But if you only have 10 milliliters, that still works better than nothing. Okay? A 4-site block works better than a 2-site block. And what we mean by 4 and 2 sites are not the site where you put for the tenaculum or the Alice, but these sites right here. So 4 sites works better than 2 sites. So most of the time people go at 8 and 4 or 9 and 3, but actually 4 sites works better. And then slow injection of the lidocaine, not fast, and deep injection, meaning 3 centimeters deep. So you're going pretty deep in, works better as well. So this is the block that we know works the best at this point. So this is the one that's recommended. So when you do the MVA procedure, you want to make sure to prepare the patient and including a bimanual examination so that you can make sure you know what her uterine size is and then what cannula you might be using, because usually we match the size to the cannula. You're going to clean off the cervix. You're going to perform your paracervical block. You're going to dilate the cervix if it's not dilated. You're going to insert the cannula. You're going to do your MVA. You're going to inspect the tissue and then perform any other procedures, like if you're putting in an IUD or doing her implant or anything like that, and then watching her afterwards. So pretty simple. Now, we talked about cervical priming or cervical ripening. It's not necessary for folks that are before 12 weeks. After 12 weeks, if the cervix is not open, then we do this to make it safe. But in the first trimester, it is not needed. Now, for some folks, if they feel like a woman's only had cesarean sections before, or might be on the higher edge of the 12 weeks, or is a nulliparous patient, sometimes they'll do a cervical ripening to open the cervix before the procedure. And these are kind of the different ways that you can do that. Antibiotics are recommended before vacuum aspiration procedures, whether you do electric or manual. If antibiotics are unavailable, then it's still fine. You should still do the procedure. We recommend a prophylactic dose, which is kind of like a one-time dose, not a treatment dose, unless you think that there's an infection, and then obviously treat with the treatment dose. So these are the typical regimens that you would use just for the prophylactic dose. All right, so these are kind of some of the questions we get about the MVA, because you know, an MVA does not last forever. I know a sharp curette lasts forever, but an MVA does not. So if something is cracked, if you can't create the vacuum, if the buttons are broken, if things don't hold in place, or you can't get a vacuum, it's time to throw it away. Okay. Why isn't the vacuum not working? Well, you might not have put it together right. You might not have actually created the vacuum. Sometimes people forget to push the buttons or forget to pull the syringe back. Your O-ring may not be in the right place, or your person may not have put the O-ring on, or they may have stretched out the O-ring or put a hole in it. And so you might need to get a new O-ring, and you can get a new O-ring. So you can get a little subset. You can buy a little subset of O-rings if you need them. You might have too much lubrication, and then there may be some other things that are happening too as well. And then what happens if you're using the vacuum and all of a sudden it stops vacuuming? Well, it may be that it's full. You might have taken the cannula all the way past the cervix and then you don't have a vacuum anymore. The cannula is clogged, so sometimes you get the sac at the top of the cannula, so you just take it out, take the sac off, recharge the MVA, put it back in, or you didn't put the aspirator together right. The other really important thing is, if you are ordering this for your clinics, there are a couple different MVAs. The single valve syringe works basically the same, and you can also use this one multiple times. However, there is a double valve syringe that's a one-time use only, that's used in a lot of high middle income countries, because then they don't have to worry about somebody cleaning it and putting it together wrong. This one, if you have one that's blue, that's a one-time use only device. It's supposed to be thrown away afterwards. So if you want to use a device that you can use multiple times, do not order this one, okay? And then you can also order dilators too as well, but oftentimes people use the cannulas instead as dilators, so you don't have to use the dilators if you don't want to. But they're really nice because they have this little curve to them, so it makes it really easy to get into the cervix and the uterus. If you're interested in kind of the global standard for abortion and post-abortion care, that's the WHO Safe Abortion technical guidance. That is free on the web to you guys. You just go to the WHO website. And then IPASS has clinical updates in reproductive health that are also available publicly. And they're updated every 1 to 2 years, whereas the WHO is probably updated every 5 to 10 years. It's undergoing an update right now, so it should be out pretty soon. Whereas IPASS bases their guidance on WHO, but then updates it with all the evidence that's coming out. And that's my university. So that's it for the MVA talk.